Hello viewers, good day to all of you. Today I am here to discuss with one more topic on the lower limb, which is the medial compartment of the thigh. So the medial compartment of the thigh is also called as the adductor compartment. So in this lecture mainly we are going to understand how the structures in the medial compartment are arranged. So that is the orientation, followed by the cutaneous innervation. So that is the superficial structures. The skin and the superficial fascia is innervated by which muscles, which nerves, branches of which nerves, and the muscles which represent the medial compartment. So what are all the muscles which are present in the medial compartment? Their origin, insertion, nerve supply and action. Then the arteries and the nerves which are present in the adductor compartment. Then of course finally we are going to discuss about an important region in the medial compartment, that is the adductor canal. Now coming to the medial side of the thigh, so here you are able to see the medial side of the thigh, this part. Mainly the cutaneous innervation is going to be the upper medial side of the thigh is going to be supplied by the ilioinguinal nerve. So the upper medial side of the thigh is going to be the ilioinguinal nerve, and more laterally we have seen it is by the femoral branch of genitofemoral nerve, the front of the thigh along the skin covering the femoral triangle. Okay, so the ilioinguinal nerve supplies the upper medial side of the skin of the thigh. It is again a branch from the lumbar plexus having a root value of L1. Then little bit medial you come, it is by the cutaneous part of the obturator nerve. Okay, so obturator nerve is again going to divide into anterior and posterior divisions, of which the anterior division takes part in the cutaneous innervation. It is going to mainly supply your middle 1/3 of the medial side of the thigh. Then followed by that, the lower part you have the posterior branch of the medial cutaneous nerve of the thigh. The medial cutaneous nerve of the thigh is again a branch from the anterior division of the femoral nerve. Okay, it is from the anterior division. So two branches mainly from the anterior division, cutaneous branches, the medial cutaneous nerve of the thigh, and the other one, you know that you come a bit laterally, you have the intermediate cutaneous nerve. These both are branches, cutaneous branches from the anterior division of the femoral nerve. Regarding these two branches we have seen well and enough in the front of the thigh and also in the femoral triangle. Okay, so mainly the ilioinguinal nerve, middle 1/3 it is by the obturator nerve, anterior division of the obturator nerve, and lower part it is going to be by the posterior branch of the medial cutaneous nerve of the thigh. And little more down you come, it is going to be the saphenous nerve. Okay, so that is about the cutaneous innervation of the thigh. Now coming to the orientation of the structures present in the medial compartment. So mainly you have the muscles. The bulk of the medial compartment is formed by the muscles. The medial most muscle is going to be the gracilis. Then you have the adductor muscles, adductor longus, brevis and magnus. Of course one more muscle can also be included, but we have already discussed that in the floor of the femoral triangle, that is the pectineus muscle. Okay, then the blood vessels, mainly the profunda femoris artery, which is going to supply the medial compartment, and the nerve of the medial compartment is the obturator nerve. Okay, so these are the structures which are present in the medial compartment of the thigh. So mainly your muscles, then you have the blood vessels, the profunda femoris artery, and upper part will be supplied by the obturator artery, and then the nerve is going to be the obturator nerve. So we are going to discuss about these structures one by one. So a cross section of the thigh gives an orientation about the structures in the medial compartment. You have the three compartments, that is the anterior or the extensor compartment, then you have the posterior or the flexor compartment, then you have the medial or the adductor compartment. They are all divided by the intramuscular septa. You have the lateral intermuscular septa, then you have the medial intermuscular septa, and then you have the posterior intramuscular septa. The adductor muscles are actually present between the medial and the posterior intramuscular septum. Okay. Of this, you are able to see on the medial compartment the more massive muscle, the adductor magnus, which is present at a more deeper plane. So, more superficial plane, you will have the gracilis muscle, then you have the adductor longus and pectineus muscle, then you have the adductor brevis muscle, and more deeper you have the adductor magnus. The adductor magnus actually falls under two compartments. The medial compartment also it shares, and also the posterior or the flexor compartment of the thigh. It comes or falls under the two compartments, so that is why it is also called as the composite muscle. So, muscles of the medial compartment of the thigh, now we are going to concentrate on the muscles of the medial compartment of the thigh. Mainly they are arranged in three strata or layers. The superficial layer mainly consists of the pectineus, the gracilis, and the adductor longus. So, the pectineus muscle we have seen here, then we have the adductor longus and the gracilis, which is the medial most muscle, as I told you. So, pectineus muscle we have already discussed about the pectineus muscle, which arises from the pectineal line or the pecten pubis and getting inserted into the base of the lesser trochanter and also into the upper part of the spiral line. Okay, that is the pectineus muscle. It is also a hybrid muscle because it has got two nerve supply, the femoral nerve and also from the obturator nerve. The other two muscles are the gracilis and adductor longus, which is present in this layer. The intermediate layer is mainly occupied by the adductor brevis muscle alone, and above you have the obturator externus. Okay. Then the deeper layer mainly consists of the adductor magnus, this massive muscle, which is part of it is hidden from your view by the adductor longus and the brevis muscle. So, the gracilis mainly arises from the inferior ramus of pubis, inferior pubic rami, and also from the conjoint ischiopubial rami. Okay. So, this forms the pubic arch. Near to the margin of the pubic arch it is attached. So, that is the gracilis muscle from the inferior ramus of pubis and also extending into the conjoint ischiopubic rami. It is getting inserted into the upper part of the medial surface of the shaft of the tibia. Okay. So, medial surface, upper 1/3 of the shaft of the tibia, medial surface only receives the muscle attachments. The remaining part of the tibia, there is no muscle attachment. It is completely subcutaneous throughout its length. Okay. So, the nerve supply is mainly to the anterior division of the obturator nerve, which is going to supply this gracilis muscle. The gracilis muscle is actually a powerful adductor of the thigh and also a flexor of the knee. Okay. It is an adductor of the thigh and flexor of the knee. So, that is why it is actually called as the gracilis. So, it is a strong adduction. It helps to adduct your thigh strongly, both the muscles when you adduct, both the thighs are approximated, and also it is a flexion of the leg or the knee joint. Okay. So, it is also a flexor of the knee. So, these two acts enable the women to maintain their virginity. So, that is why it is actually called as the gracilis muscle. If you look at the insertion of the gracilis muscle, the sartorius muscle from the extensor compartment, then you have the gracilis muscle from the medial compartment and the semitendinosus from the posterior compartment. These three muscles get inserted at the medial surface, upper 1/3 of the medial surface of the shaft of the tibia, like the crow's feet. That is why it is actually called as pes anserina. It is actually called as the pes anserina, and they also form gyropes. So, what is gyropes? I will be discussing that in the posterior compartment. So nothing, they are actually again stabilizing your hip on the lower limb. Okay, so they are actually stabilizing the hip on the lower limb, so that is why it is actually called as the guy ropes. Coming to the next muscle, adductor longus muscle, you are able to see this is the adductor longus muscle. From the anterior surface or front of the pubic bone, immediately below the pubic tubercle, is the origin of the adductor longus muscle and gets inserted into the medial lip of the linea aspera just lateral to the vastus lateralis muscle. Okay, so it is getting inserted into the medial lip of the linea aspera. It is supplied by the anterior division of the obturator nerve. So the anterior division of obturator nerve mainly supplies your gracilis, and then also it supplies your adductor longus muscle. It is an adductor of thigh. Again, it helps in adduction and medial rotation of the hip joint. Okay, medial rotation of the hip joint and also the adduction of the thigh. So that is the action of the adductor longus muscle. It also forms one of the boundaries for the femoral triangle, and it also forms floor of the femoral triangle. Rider's bone. So near to the origin, what happens is there might be in the tendon of the adductor longus, the tendon might get ossified in the riders. That is why it is actually called as the rider's bone. Okay, so who? Mainly in the horse riders. Okay, the horse riders, what happens is the part of the tendon near to its origin, the adductor longus tendon might get ossified, and that is represented as the rider's bone, especially in the horse riders. The next muscle is actually the adductor brevis muscle from the inferior ramus of the pubic bone, and again getting inserted into the linea aspera of the femur. Getting inserted in the linea aspera of the femur, supplied by the anterior division of the obturator nerve. If it is not supplied by the anterior division, sometimes it might be supplied by the posterior division of the obturator nerve. So it lies at an intermediate plane. So in front of it you have the adductor longus and pectineus. Upper part you have the obturator externus. The lower part, or deep to that muscle, or behind or posterior to that muscle, you have the adductor magnus muscle. Again, it is an adductor of the thigh, but it's a lateral rotator. Okay, so mainly what happens is adductor longus is a medial rotator, whereas adductor brevis is a lateral rotator. Gracilis, apart from the adduction, it is also a flexor of the knee. So kindly make a note of the accessory actions of these muscles. Apart from primarily being the adductors, they also perform other accessory actions like flexion of knee, lateral rotation and also the medial rotation of the thigh. The next muscle what you see here is the adductor magnus muscle. The very large extensive muscle you are able to see here, that is actually the adductor magnus muscle. It has got two parts. The adductor part arises from the pubis, and the flexor part actually arises from the ischial tuberosity. Okay, so from the inferior ramus of pubis, the fibers arise, mainly the adductor or the pubic part, and again they get inserted into the linea aspera and medial supracondylar line. Okay, linea aspera and the medial supracondylar line or ridge, whereas the ischial part arises from the lower area of the ischial tuberosity and getting inserted into the adductor tubercle, and there is an opening or a hiatus between the insertion of the adductor part and the ischial part. So that is the osteoaponeurotic opening. Apart from that, the adductor magnus also has openings or pierced by the perforating arteries from the profunda femoris, especially the second, third and fourth perforating arteries. They pierce this adductor magnus muscle. If you look at the uppermost border of this adductor magnus muscle, it lines in line with the lower border of the quadratus femoris muscle. So quadratus femoris, okay, not the rectus femoris. Rectus femoris is present in the extensor compartment. Quadratus femoris we will see in the muscles of the gluteal region. So the medial circumflex femoral artery will pass between the gap between this quadratus femoris and the upper border of the adductor magnus muscle. If you look at the fibers of the adductor part, again you are able to see they are almost transversely oriented, whereas these fibers are mostly vertically oriented. In lower forms and in some vertebrates, the adductor magnus directly goes and gets attaches to the tibia, and it is also called as the pre-semitendinosus muscle. Okay, but in humans what happens is it is restricted only to the adductor tubercle, and the lower part of the adductor magnus continues as the tibial collateral ligament. So the tibial attachment in case of humans is represented as the tibial collateral ligament. The nerve supply of the adductor part is mainly supplied by the posterior division of the obturator nerve, and ischial part will be supplied by the sciatic nerve, mainly the tibial component of the sciatic nerve. So that is the adductor magnus. As I told you, it has the openings mainly for the 4 perforators, and the 5th opening, the femoral artery itself, is going to continue as the popliteal artery, which is called as the adductor hiatus. So the pubic part mainly is in the adduction of the thigh, whereas the ischial part is helpful in the extension of the thigh. Okay, extension of the thigh. Here I would like to also mention that all movements of the lower limb is also accompanied with the movements of your pelvis or the pelvic girdle. Okay, the pelvic girdle also moves along with the movements of the your lower limb. So that again we will be discussing in the hip joint class. Okay, so that is the attachment into the adductor tubercle through which passage of the femoral vessels takes place. So collectively, if you look at the muscles, the adductor group of muscles, adductor longus, brevis and magnus, they arise somewhere starting from here, pubis, in front of the body of pubis, then inferior ramus of pubis, then collectively ischiopubic rami, and from the ischial tuberosity. So like that, extensive origin by the adductor longus, brevis and then the adductor magnus, and basically where they are getting inserted into the linea aspera. So they are actually passing behind the femur and getting inserted into the linea aspera. The upper part mainly here insertion into the lesser trochanter, base of the lesser trochanter, and upper part of the spiral line, it is going to be the pectineus muscle. One more muscle which is going to origin is the obturator externus muscle. So around the margins of the obturator foramen, and this foramen will be covered by a membrane which is actually called as the obturator membrane. Even from the obturator membrane, the obturator externus muscle originates, except in the gap here where you have the obturator foramen and the obturator canal. Except from that, the whole of the membrane and around the margins, it is going to get inserted into the trochanteric fossa. So it is getting inserted into the trochanteric fossa. Are you able to understand? So the trochanteric fossa is the depression seen on the medial side of the greater trochanter, the obturator externus. Again, it is going to be supplied by the anterior division of obturator nerve, and it is also a lateral rotator of the thigh, obturator externus. Apart from that, the gracilis muscle we have already seen. It is the only muscle which is going to extend into the tibia, from the adductor compartment. So now coming to the artery, the chief artery or the arterial supply to the medial compartment of the thigh is by the profunda femoris artery. So approximately it arises 3.5 centimeters or 1.5 inches below the inguinal ligament. So it originates from the posterior lateral part of the femoral artery, and it descends in the interval between the adductor longus and brevis, and then between the brevis and the magnus, and finally what happens, it ends as the fourth perforating artery in the vastus lateralis. It ends actually as the fourth perforating artery, profunda femoris artery. So here you are able to see the profunda femoris artery, which is lying successively on the adductor longus and brevis, and then between the brevis and the magnus muscle. So these are the perforating arteries which are given the fourth perforating artery or the last perforating artery, thereby it terminates. It also gives two other branches. The branches are, apart from the perforating arteries, the medial and lateral circumflex arteries. So you are able to see the lateral circumflex and the medial circumflex artery. So the medial circumflex artery actually passes medially, winding around the femur between the adductor longus and pectineus, and it gives three branches. The medial circumflex artery will give three branches. The transverse branch, the ascending branch, it will give a transverse branch, and it will also give an ascending branch, and it is also giving an acetabular branch. The transverse branch will take part in the cruciate anastomosis around the hip joint. Okay, the cruciate anastomosis behind the femur, you are able to see it will be formed by the transverse branch of medial circumflex, transverse branch of lateral circumflex, descending branch from the superior gluteal artery, and also a branch from the inferior gluteal artery. The inferior gluteal artery and from the ascending branch of the first perforating artery takes part in the cruciate anastomosis. Then I told you it has got an ascending branch will actually take part in the trochanteric anastomosis. So between the ascending branch of the lateral circumflex, ascending branch of the medial circumflex, and also branches from the superior gluteal artery. Then you have the lateral circumflex artery. The lateral circumflex artery again will give an ascending branch, a descending branch, and a transverse branch. The transverse branch takes part in the cruciate anastomosis. Ascending branch will take part in the spinous anastomosis along with the branches of the superficial and deep external pudental artery, and also with the branch of the superior gluteal artery, superior descending branch of the superior gluteal artery. The descending branch passes downwards and takes part in the genicular anastomosis. So it will anastomose, takes part in the superolateral genicular anastomosis. That is about the lateral circumflex femoral artery. The descending branch takes part in the anastomosis around the knee joint. Then you have the four perforating arteries. They are branches from the profunda femoris artery. The fourth perforating artery termination, it is a termination of the profunda femoris artery. So they pierce the adductor magnus and ends near the vastus lateralis muscle, and each perforating artery divides into an ascending branch, descending branch. They anastomosis, thereby they form a vascular chain of anastomosis. The descending branch will anastomose with the popliteal artery, and the first ascending branch will anastomose with the inferior gluteal artery, taking part in the cruciate anastomosis. So they are actually actual anastomosis rather than potential anastomosis. So which means there is always, it is a functional anastomosis where the blood supply is taking place. Collateral circulation takes place through the perforating branches of the profunda femoris artery. So these are the anastomosing branches. For as I told you, the ascending branch takes part in the cruciate anastomosis, descending branch anastomosis with the popliteal artery. So profunda femoris vein follows or accompanies the course of the profunda femoris artery, and finally it is going to end in the femoral vein. So actually it is a branch or it is a part of the deep vein. So these are the various types of the profunda femoris vein which you are able to see here. So mainly it will end in the femoral vein, or it will join the femoral vein, form the common femoral vein, or sometimes the femoral vein will form a superficial femoral vein. This forms a deep femoral vein, and finally they will end as common femoral vein, draining into the external iliac vein. Obturator artery, you are able to see here the obturator artery. It is a branch from the internal iliac artery, anterior division of the internal iliac artery. So you are able to see that is the internal iliac artery. From the internal iliac artery, from the anterior division, what you see is the obturator artery. So it is seen along the lateral wall of the pelvis, lateral pelvic wall, and accompanies the obturator nerve. Then immediately what happens is it divides into medial and lateral branches. So it divides into medial and lateral branches, anastomosing on the obturator membrane. So that is the obturator membrane covering the obturator foramen. There is a small gap or deficiency in the obturator membrane through which the obturator nerve emerges, forming the obturator canal through the obturator canal. Okay. So it gives, after forming an arterial anastomosis, these branches, it gives off muscular branches and also an articular branch to the hip joint. So that is about the obturator artery. It is a branch from the internal iliac artery, anterior division of internal iliac artery. Obturator vein, so receives tributaries corresponding to the obturator artery, medial and lateral branches, and ultimately it is going to drain into the internal iliac vein. Now coming to the obturator nerve, it is again a branch from the ventral rami, ventral division of the lumbar plexus, L2, L3 and L4. So it is seen along the medial border of the psoas major muscle, the obturator nerve, seen along the medial border of the psoas major muscle in the abdomen. Then what happens? Along the lateral wall of the pelvis, apart from the medial border of psoas major, it runs along the lateral wall of the pelvis, and in the upper part of the obturator foramen, it divides into an anterior and a posterior division. Anterior and posterior division. So here you are able to see the anterior division in front of the obturator externus and also the adductor brevis muscle, but deep to the pectineus and adductor longus. So pectineus and adductor longus has been removed for you to see the adductor brevis. So it lies between the adductor brevis posteriorly and pectineus and adductor longus anteriorly. So mainly it supplies gracilis, adductor brevis, adductor longus and pectineus. Okay. So four muscles it supplies: adductor longus, gracilis, adductor brevis and the pectineus muscle. Then it is going to give an articular branch to the hip joint. It is going to give an articular branch to the hip joint and also vascular branches to the femoral artery. Vascular branches to the femoral artery. And the anterior division also gives cutaneous branches which is going to take part in the subsartorial plexus, through which it is going to supply your medial side, the middle 1/3 of the thigh. So the anterior division gives muscular branches, cutaneous branches, vasomotor branches and also articular branches, four types. So mainly it supplies the four muscles, the gracilis, adductor longus, adductor brevis and pectineus. Articular branches to the hip joint. Remind, it is actually the hip joint. I am again stressing it, not the knee joint. Then it gives vasomotor twigs to the femoral artery, and it is also cutaneous through the subsartorial plexus. It also supplies the skin over the medial part of the thigh. So that is the anterior division present between the adductor brevis posteriorly, pectineus and adductor longus anteriorly, giving branches to pectineus, adductor longus, adductor brevis and gracilis. If you look at the posterior division, it passes behind the adductor brevis. It passes behind the adductor brevis and it supplies mainly the adductor magnus muscle. It is present between the adductor brevis and adductor magnus. If the anterior division does not supply, then the posterior division supplies the adductor brevis muscle. It supplies the adductor brevis muscle. Then it descends through the adductor magnus and supplies the knee joint. Okay, so it supplies the knee joint. It passes mainly through the adductor magnus. Then what happens is it might descend through the adductor magnus, hiatus of the opening in the adductor magnus. Then it might pierce the oblique popliteal ligament and the capsule of the knee joint, and then it is going to supply the knee joint. So muscular branches to the obturator externus and the adductor magnus, mainly the adductor part. So muscular branches, articular branches to the knee joint, and it might also give vascular twigs to the femoral artery, the lower part of the femoral artery. It might give articular twigs, but it does not give any cutaneous branches. So there is no cutaneous component for the posterior division of the obturator nerve. So here you are able to see a topographic representation from L2, L3, L4, the obturator nerve seen on the lateral wall of the pelvis, anterior and posterior division. So posterior division mainly supplies articular to the hip joint, muscular to pectineus, adductor longus and adductor brevis. So here there is a question mark because it might supply and sometimes it might receive completely the nerve supply from the femoral nerve, the pectineus muscle. The cutaneous to the subsartorial plexus to the medial part of the thigh and vascular twigs to the femoral artery. Posterior division supplies adductor magnus and obturator externus. Then vascular to the knee joint, and it also gives, articular to the knee joint, the posterior division. And then vascular branches to the popliteal artery. Okay. Now, in cases of spasm of the adductors and intractable pain or intraceable pain, in case of this, what happens is you surgically incise the obturator nerve. Okay, so the obturator nerve, what happens is by division of the obturator nerve, the spasm of the adductor muscles can be relieved. Then, since the obturator nerve is seen in the lateral wall of the pelvis, so it runs along the ovarian fossa. It is related to the lateral wall of the ovarian fossa. Any inflammation of the ovary, what happens is you feel referred pain along the medial side of the thigh and also on the medial side of the knee joint. In the knee joint and medial side of the thigh, you see the referred pain in case of women. Not only that, any pathology of the hip also is referred to the medial side of the thigh through the obturator nerve, because the anterior division of obturator nerve gives an articular twig to the hip joint. So referred pain might be due to the pathology of the hip, and especially in case of women, what happens is any inflammation of the ovary, referred pain is to the medial side of the hip and also to the knee joint. So we are coming to the next aspect. So far we have seen about the muscles, the vessels and the nerves of the obturator compartment, adductor compartment. Now we are coming to the adductor canal, which is also called as the subsartorial canal or the Hunter's canal. So it is actually a musculofacial tunnel which is present deep to the sartorius muscle, in the middle 1/3 of the sartorius muscle, deep to that. It's a very narrow space. seen in the medial part of the thigh. So almost 15 centimeter long from the apex of the femoral triangle to the adductor hiatus is the extension, total extent of the subsartorial canal or the Hunter's canal. Through this, mainly the vessels, that is the femoral vessels, descend and it is going to enter the posterior compartment of the thigh, and also it transmits nerves, mainly the nerve to vastus medialis, and sometimes the obturator nerve also comes into the subsartorial canal. So mainly femoral vessels from the femoral triangle to the popliteal fossa is transmitted or passes through the obturator canal. So the boundaries, cross section, here you are able to see the boundaries. It is triangular in cross section. The subsartorial canal, which is bounded anterolaterally by the vastus medialis muscle. So anterolaterally it is the vastus medialis muscle, and posteriorly by the adductor longus in the upper part and adductor magnus in the lower part. Adductor longus in the upper part and adductor magnus in the lower part. Below. The roof sartorius. So deep to sartorius, it is actually an extension of fascia between the two boundaries, that is the anterolateral wall and the posterior wall. So between the anterolateral wall and the floor, it is a fascia which is covering them, and on top of the fascia you see a plexus of nerves which is the subsartorial plexus. Okay, so it is overlapped by the sartorius. So here you are able to see in the middle third of the sartorius, deep to that, the adductor canal is present. You have a facial roof, and the facial roof, on top of the facial roof you have the subsartorial plexus. Then what happens is, at the end, the apex of the adductor canal is actually marked by this hiatus, a gap between the adductor part of the magnus and the hamstring part of the adductor magnus. The floor is from the adductor longus in the upper part and adductor magnus in the lower part. So that is the extension of the adductor canal on almost 15 centimeter in length. So the subsartorial plexus of nerves which you see over the roof is mainly formed by the saphenous nerve, then by the medial cutaneous nerve of the thigh. So branches from the medial cutaneous nerve of the thigh, the saphenous nerve, and anterior division of obturator nerve. So the cutaneous innervation to the medial side of the thigh is by the saphenous nerve. So the saphenous nerve, what happens, it will pierce the roof of the fascia, then it will pass to the medial side of the knee and medial side of the leg and to the medial border of the foot up to the ball of the great toe. So that is the extensive cutaneous innervation of the saphenous nerve. The plexus is formed by this nerve along with the medial cutaneous nerve and anterior division of the obturator nerve. Anterior division of obturator nerve gives cutaneous innervation through the subsartorial plexus. So through this it supplies the skin and the overlying fascia lata. Coming to the contents of the subsartorial canal, you have the femoral artery, femoral vein, nerve to vastus medialis, almost a very thick large branch of the femoral nerve is the nerve to vastus medialis, and then the saphenous nerve, which is also the largest cutaneous branch of the femoral nerve from the posterior division of the femoral nerve. Occasionally you have obturator nerve also forming the content of the subsartorial canal. So the main content are the femoral artery, femoral vein, saphenous nerve, and the nerve to vastus medialis. Then the descending genicular artery, which is also given by the femoral artery in the subsartorial canal. So here you are able to see the femoral artery, femoral vein and the saphenous nerve. Then you have the nerve to the vastus medialis. It's all forming the content. Obturator nerve usually does not form, but sometimes it might form the content of the adductor canal. So then what happens from the apex of this, the femoral artery passing to become the femoral artery passing to become the popliteal artery. So the femoral artery, when you look here at the apex of the femoral triangle, the vein is actually posterior. So that means the femoral artery is slightly coming anterior. First it is lateral, then what happens, it is becoming anterior to the femoral vein. It traverses the entire length of the adductor canal and leaves the canal by passing through the aponeurotic opening between the tendon of adductor magnus and the femur bone. It gives muscular branches and also the descending genicular branch. The descending genicular branch will again give a saphenous branch which will accompany the saphenous nerve. So before the artery leaves the canal, the femoral artery, it gives the descending genicular artery. That is also going to take part in the genicular anastomosis around the knee joint. The femoral vein, apex of triangle, it is actually lying posterior in the femoral triangle, apex of femoral triangle. But then in the subsartorial canal, it completely lies behind the femoral artery, and in the lower part, it has become lateral to the artery. So we are able to see the twisting of the femoral vein and also the crossing of the saphenous nerve. All this is because of the rotation of the lower limb developmentally 90 degrees medially. So because of it, you are able to see this spiral course of the femoral nerve, femoral artery, the femoral vein, femoral artery and all this saphenous nerve. So femoral nerve, what happens is, it is behind, and then in the lower part of the canal, it is somewhat lateral to the femoral artery, and that is the course of the vein in the adductor canal. Saphenous nerve, you are able to see from the posterior division, largest cutaneous branch. It crosses the artery in the adductor canal from lateral to medial side. So in front of the artery, it is crossing. So front of the artery is crossed by the saphenous nerve from lateral to medial side. Behind the artery is crossed by the femoral vein from the medial to the lateral side. Then it pierces the fibrous roof, and then only it becomes cutaneous. So just before exiting from the adductor canal, it gives an infrapatellar branch which is going to join the patellar plexus and supplying the skin over the patella. That is the prepatellar skin. So saphenous nerve is going to give a prepatellar branch, and then it is going to become cutaneous to the medial side of the leg and medial border of the foot. Then you are able to see the next content is the nerve to vastus medialis. As I told you, it is one of the thickest branch of the femoral nerve. So it is somewhat located lateral to the femoral artery and enters the vastus medialis in the upper part of the canal. Nerve to vastus medialis supplies the vastus medialis muscle, and it is also going to supply the knee joint, articular branch to the knee joint. So that is the nerve to vastus medialis, which is present somewhat lateral to the femoral artery. Occasionally the posterior division of the obturator nerve. Okay. So here you are able to see the posterior division of the obturator nerve sometimes forms, and it ends by supplying the knee joint. So the most clinical significant, why it is actually called as Hunter's canal, John Hunter's canal or adductor canal, because the surgeon John Hunter, what happens is, he ligated the femoral artery here to treat the popliteal aneurysm. Okay. So popliteal aneurysm is abnormal narrowing of the popliteal artery, aneurysms of the popliteal artery. So the femoral artery is exposed and ligated not only to treat popliteal aneurysm but also to control any bleeding of the femoral artery. Naturally what happens, the femoral artery is ligated to control any bleeding of the popliteal artery also. So John Hunter was the first to perform this procedure in this region, so that is why it is also named as the Hunter's canal. So after ligating the femoral artery, naturally the genicular branches and anastomosis around the knee joint takes place. It is taken care of, the blood supply is by the collaterals around the knee joint to the area below this ligation. So that is the applied anatomy. Then apart from that, you also have adductor canal block. Local anesthetic is injected or administered in the adductor canal to block the saphenous nerve, so to thereby to anesthetize the medial side of the knee and also the medial side of the foot. So anesthesia along this region to perform any procedures, and also it actually anesthetizes the nerve to vastus medialis when you give a block in the adductor canal region. So sensory anesthesia involving the distal thigh, femur, knee and lower leg on the medial side. So one is the adductor canal block. The previous one what we have seen is the ligation of the femoral artery to treat popliteal aneurysm. So mainly to find out this, the sartorius muscle and the femoral artery are used as the landmarks to perform this adductor canal block. Okay, so injecting an anesthetic agent in the subsartorial canal to provide sensory anesthesia to the medial side of the thigh, leg. So with this, I have completed the medial compartment of the thigh and the adductor canal. So thank you for your patient listening. We will meet again in one more lecture.